You're listening to Healthy Discussions, a podcast supported by the Healthcare Leadership Academy, where we have conversations exploring big ideas in healthcare with our guests. I'm Zach Hassan, a junior doctor from Scotland. If you're interested in how we can make the health system better, then this is the podcast for you. Today I am talking with Dr. Sarah Keir. Sarah is a consultant stroke physician at the Western General Hospital in Edinburgh, where she is also the lead for quality improvement of the medicine of the elderly department. Her academic publications have been cited over 1,000 times, according to the ResearchGate website, and I've also had the pleasure of working with her directly as she was one of my supervising consultants. I found her to be an inspiring physician to work with, and I wanted to have her on the podcast because I knew that there was a lot of thought that has gone into her quality improvement work, and that there would be lots we could talk about. We discuss why things go wrong in hospital and how to make them better, and what individual and organisational considerations might need to be made in order to do that. I hope you enjoy. Sarah, welcome to the podcast.
Hello, nice to be here.
And it's really great to have you. You're actually the first consultant that I've personally worked with that I've had on the podcast, so it's a lot of firsts.
Excellent.
But I was wondering if you could give us a flavour of what your day-to-day job is like and what you actually do in terms of patient care.
So I'm a geriatrician in Scotland, and that means I look after people who at the older end of the frailer end of the spectrum. We have a large footprint at the Western General, over 150 beds, and I have responsibility for some acute admissions and reviews of those patients. And I'm also a stroke physician, and so my ward is particularly concentrated on stroke recovery. So that's what my sort of day-to-day general sort of work schedule is. I also have a sort of role for Lothian as head of realistic medicine, which is something we might want to talk about.
Can you define what realistic medicine is for us? Like, what does that mean?
It's a concept that pretty much most national medical sort of organisations have, and it's called different things in different places. It effectively means practicing patient-centred care with a minimum of waste and variation. So patient-centred care is something that everybody uses a lot, but actually it actually what it means is not only, yes, that you're focusing on the patient and what you're thinking of how you can apply your knowledge base to that patient, but also how can you bring that patient into the conversation of what to do for the best for their medical care.
Mm-hmm.
That's something that certain parts of, I would say, our profession have moved away from because they are so knowledgeable and capable that they're very willing to transmit that information, and this is what I think should happen to you. And sometimes we're not that good at listening to what the patient is trying to tell us about what they need. So it's a movement to try and bring the patient back into the center of that conversation. In England, it's called choosing wisely. In Italy, it's called medicina lenta, slow medicine. It's not about restricting. It's about what's the best for the person in front of you.
Mm-hmm. And I don't think any patients would argue with having more of a say over what happens to them. And as we're going to talk about when things go wrong in medicine and sort of medical error, like that becomes more important, doesn't it? How have you seen those conversations changing over your career?
Well, I'm going to come back to that point as well about the fact that the realistic concept is not just about getting the medics to think correctly. It's also getting the people who are going to use those medical services to think correctly too, because that then certain people think that the medics are absolutely wonderful. They can just do everything or amazing amounts of things that will make them feel better, but don't have a particularly good concept of the potential risk that could come about from that. So that's the other part of the conversation, and that brings in the things that can actually go wrong as well as right, which is the things that got me interested, particularly in looking at quality improvement and safety.
Is there a
So
story behind how you got involved in quality improvement? Maybe some people listening to the podcast will be like, I thought the NHS was brilliant at everything. Of course, medicine's advanced so much. Why would we need to improve the quality any further?
Yeah, it is medicine. I suppose I'll tell you how. For my story, Zach, is that I was a geriatrician, which means I turned into a geriatrician because geriatrics seemed to be the place where you could practice a holistic type of care, where you try to fix the problems for the person in front of you rather than concentrated on a specific organ, and that sort of fitted the way I like to practice medicine. And also, I think I was impressed by the clinicians that were in medicine for the elderly, geriatric medicine, and that's kind of what I wanted to emulate. I've always been particularly interested in the brain and the neuro side of things, and stroke was a natural progression into that. And stroke is a strongly evidence-based practice these days, probably particularly for the last 20 years. But
it wasn't always like that.
No. I mean, like I say, it was a lot in the 20th century. An awful lot of what we practiced, Zach, was eminence-based medicine rather than evidence-based medicine. As in, the great and the good consultants who'd had 30 years experience were treated as the oracles without necessarily the evidence base behind it. And yeah, that was as good as we had. Then along came randomized controlled trials, and then big, large, multi-center randomized controlled trials that became very powerful with the evidence. And then because that allowed us to be more confident that the decisions we were making were based in what was likely to happen. And I think there's nothing wrong with eminence, with opinion when there is evidence lacking. And there's also evidence alone without thinking of the person in front of you is a limited treatment option. So you need both of those things. But one of the things that you do see in, for instance, secondary prevention is that the evidence suggests that our capability of affecting a good or a bad difference is actually a small percentage points around the likelihood of what's going to happen. And what I would see on my day-to-day practice is that things were happening that could impact on the person's care or progress to a sizable degree, probably more than the medicines that the doctors were particularly interested in, or the things that we concentrate on, the medical side of things. And so it seemed that we needed to bring those things back into the round. We needed to be making sure that we were implementing the evidence that we knew, rather than thinking, I don't like that piece of evidence, I'm going to do what I want, or which still regularly happens. But also these things that are making the patient journey or experience worse are having a negative impact. Can we get those things out? Can we make sure that they're not likely, or they're least likely to fall on the ward when they're having their recovery? Are they getting the right nutrition? Are we making sure that they're not being exposed to potential dangerous infections, things like that? All of those things matter, and that's where quality comes in. Quality standards, trying to practice the best care you can. Just seem pointless just to concentrate on the tablets.
Mm-hmm. So how has that sort of quality improvement methodology, that idea of measuring things, how has that impacted on the behavior of the sort of eminence-based consultant? Because my impression of so the impression that I get from people is that eminence-based medicine, it wasn't as good, but also patients didn't complain as much when it went wrong. where, they were just grateful back then that, they were being looked after in somewhere, even if the care that they were getting actually wasn't evidence based. Whereas now, the expectation seems to be, well, if you do anything that's suboptimal, then that could be a cause for complaint. Do you think that's like a fair enough narrative, or
That's a really interesting impression you've got there, Zach, I think. I think it's rooted in what you say, but I think that there's a lot of positives you can take from that too. A dean of one of the London medical schools, Cyril something, I can check the name for you after this. It said about medicine that it used to be relatively safe, relatively inexpensive and cheap, and then with as things progressed, we now have really quite effective, ineffective, basically time fixed you or it didn't, whereas now we have some very highly effective treatments that have a significant risk attached to them. Take thrombolysis for strokes, for instance. You can dissolve that clot in the brain, but that comes with a disconcerting risk of potentially bleeding to the point where you might not survive. And also these highly effective treatments, particularly some of the new antibody-based immuno treatments, can be exceptionally expensive. So it's all about how do you juggle that risk and benefit. Coming back to your point about measurement, people get very certain about what they think is right. And an old prof of mine said, "Nothing ruins a beautiful hypothesis like cold hard fact." And that's where measurement comes in. So you can think, we're pretty good. Well, okay, you think you're pretty good. Well, measure yourself. Are you as good at avoiding hospital-based infections as you think you are? Are you as good at preventing falls as you think you are? And lovely if your hypothesis is proved correct, but also if it's not proven correct, then do something about it, improve it. And so there's two parts to the improvement story: the patient story and the data. So no story without data, no data without story. The whole point of doing measurement is not for measurement's sake, it is to improve the patient's welfare and care. So if you're going to measure something, do something with that information. But it is a powerful tool to bring people with you on the journey. Actually, guys, well done. We are very good. We haven't had a staph-based bacteremia from a peripheral cannula for 2 years. Everybody deserves fabulous congratulations. Or, we have a challenging increase in falls rate on this ward. Let's have a think about what we can do about that. So it just helps you. And look what happens when we improve things, the falls rate. So you can prove to people that in these hard pressed times where everybody's working very, very hard, that the extra effort they're putting in to try and change something for the better is working.
You slightly preempted my next question in that, how do you know what things you want to measure? Because it's important to, I suppose what I'm thinking about here is, well, what actually are the causes of medical error on the ward? And why is that happening? What's the difference between, say, we want to improve our rates of this infection on the ward, and then patients feeling like something has actually gone wrong with their care in terms of negligence?
Well, let's start with safety and challenges on the ward. The easiest way to think about it is there are national programs, England, Scotland, everywhere, that will tell you what there's national data that shows you where the potential sources of harm in a hospital or in a referring system from primary care are, and that will signpost you at the things that we should have strategies to try and reduce the capability of. Let's take hospital-acquired infection. You come into hospital to try and get better. You come into hospital for an operation to take your gallbladder out. So you say you're having a gallbladder out. You don't want to come out of that with having had an MRSA infection that you caught whilst you're in hospital. That is something that would be error. You could call it an error, patient safety. It's something that we absolutely have to try and make sure our systems and processes are in place to absolutely reduce the chance of that happening. You don't come into hospital to catch COVID from the patient in the bay next to you. So we need to try and reduce the chances of that happening as best we possibly can. We can't just ignore it. And also, coming to that, the person who comes into the hospital has to have a bit of an awareness that hospitals have challenges as well as expectations of improvement. And I
Yeah, that
think if
we're
we're all,
limited in the terms of the resources that we have to actually fix problems or
if
prevent
you're in
them.
let's take a respiratory based virus catching, if you're in a 4-bedded bay, which many hospitals, that's a common ward sort of ward sort of configuration, then it, depending on the ventilation and capability, it can be very challenging to try and stop those types of respiratory based infections, especially if they're very, very infectious. So these are the things that are a challenge that you can absolutely try and mitigate, but you can't necessarily promise cannot happen. But if you have, and this is where it comes to about standards, if you have a mindset of achieving as much excellent care as you possibly can within the resources you have, then you, at the very most, you mitigate that risk as best you can. And that means that you have a process that says we monitor our respiratory infections, we monitor if somebody catches a hospital-based infection, we change things if we see trends happening that suggest that we aren't doing as well as we should. And this is something we'll come to possibly further on, and we will tell people about that. We won't just hide it under a bush somewhere. So you, depending, and there will be slight differences about what is the important thing in your department to measure. So as a medicine for the elderly physician, the things that we know that is the greatest risk to our patients is that they're very frail, they can get very easily confused, and when they come into hospital they can fall, and if they fall sometimes they can break something, and that is by far the greatest risk of harm to patients in medicine for the elderly. If you are in intensive care, you'll be more interested perhaps in a ventilator associated pneumonias, for instance. If you're interested on a surgical ward, it may be the rate of surgical complications that you have with a certain procedure. So you will have slight differences. There's some overall things that we need to be sure of. Skin care, making sure people don't get pressure damage, and people who are, when they're poorly, they can't move. But there may be specific different measurements that you want to check in each part of that. Coming on to your idea of complaint. People have unsatisfactory experiences for a number of different reasons. And it behoves us, again, if you have an aspiration for excellence of care, which frankly you should, I think you should. That's where you start. You do your best. You aim to treat everybody as you would want somebody that you love to be treated. That's what my aim is. That you make it best they can. But we have challenges of resource, which means that patients' expectations might not meet what we can do. They may have to wait longer for something than is comfortable. If you're agony with a hip that needs an operation, and you have to wait many, many months into years to get a hip operation, that understand when you have contributed to a nationalized health service through your national insurance, and you pay for taxes, you could argue that you're not paying Scandinavian level taxes, but but you have paid for that, so therefore you have an expectation of delivery. So there may be a reason there. We have communication challenges. Different people need different amounts of communication, and us providing a one size fits all may not be enough for some people. They may well need things to be said more than once for them to understand. they may need to have things explained in a different way for them to understand. So we need to make sure that we're explaining things that make sense to a person so they can understand in this highly unfamiliar environment to a person that what the heck is going on. Because we work in this situation, we get very familiar. We forget how odd and unpleasant and frightening being in a hospital can be, even if you're just a visitor. Never mind if you're a patient in one of those gowns that leave you with no modesty and you don't know where the toilet is and it's all very frightening and nobody tells you what's going on. That's not a fun place to be, and we need to make sure that we can make that as comfortable as possible for people, and we do that a lot with communication. And when we are challenged from a staffing point of view, and when time is pressed, one of the things that tends to slip is communication. And that is something that we just have to continue to strive to deliver. If something does go wrong, if there is an error, if somebody does get an infection from a cannula, if somebody does have a fall in the hospital, then we have to be absolutely straight away upfront about that and apologize that that was not what we would hope to have happened. That was not that fell below the standard that we wished, and that we're sorry that that happened, and that here's the things that you can be assured of that we're going to do to try and
This is
make it
the
as good as it
duty of
can be.
candor, the idea
Duty
that,
of candor.
but because historically people wouldn't have felt the need to be honest about these things happening.
You're absolutely right, and there was and it wasn't necessarily, Zach, because they didn't. Sometimes when things went wrong, but things were okay in the end, people thought, well, I don't need to upset somebody by telling them that, and I can kind of see where they came from that. But to me, having lived through that period when people just sometimes explained but sometimes didn't, there was no obligation to, and then to the duty of candor years, I am absolutely on the duty of candor side of things, because you don't know what's down the line. The more open and honest we are with the people that we care for, the greater you can have a shared decision making capability. Yes, it might make you and your team look slightly less golden, but if you can explain that actually that wasn't our standard and we are disappointed in ourselves and we're going to improve on that, then you can reassure them that the overall standard of care was good. I think if you don't share, it then creates a common situation with people where they wonder, well, what else are they not telling me? So I think duty candor is very, very helpful. It can be painful, but the time to do it is pretty close to the event rather than when something else has turned up.
So at this point, we've kind of mapped out, why medical errors happen, in resource limited settings, and how we can measure things to, over time, try to do something about that.
Well, I suppose I'm going to jump in about, it's not always about resource. Medical error, we mentioned about, yes, resource is a challenging, that's a system safety challenge. I think it's only fair to put into the point that the other source of, systems are very one part of the reason why things fall, because of and such things like resource or environment and stuff. But one of the other big areas is humans. Human factors, as they're called, that humans come to work and try in our job, and we try and get people better. That's what we absolutely come to work to do. Sometimes we can't do that, and sometimes that is because there is human error in the system. So there's a whole other part of quality improvement that needs to analyze, manage, and support and fix the errors that happen by the humans in the system. So that's
I'm so
another
glad you've
factor.
said that, because this is the part of this issue that really interests me. So you can measure a lot of this data that says, oh, things could be a little bit better if we do this. And on the one hand, part of your role is to make sure that things are getting better and to try to implement the systems that achieve that. But then people watching the news will, think of scandals like the mid staff scandal, and they think of the Ockendon report, where the NHS, and I can't remember where it was now. I think it was like was it Suffolk? And they had this idea that they really wanted to have the C-section rates very low, and people died because of that. So in your experience, like, what makes that difference between people responding to error well and people responding to error badly? And how do you make sure as a doctor that you're responding to it well?
Wow, what a beautiful question. The thing that absolutely fascinates me, Zach, the more I do of this is culture, is culture and culture change, because fundamentally that's what it's about. You can feel it almost, and there's the individual, and then you've got the systems and the hospital wide thing. So let's start with an individual mistake. So the way you approach an individual mistake, I think, is with what's the concept, as a good concept called the fair and just culture, which is, if somebody makes a genuine mistake, first thing you do is console them, because they will be devastated that they did that. And I've worked with colleagues who were part of a mistake that was so tragic to them that they changed career. Adam Kay. I was just reading an article about him at the weekend. That's exactly what happened to him. So you console and you coach. Let's make you better. Let's get something good out of this. And that's what our morbidity and mortality meetings and our quality improvement meetings are. Something didn't go as well as we planned. Let's shore up our defenses, and let's get something better out of this thing that didn't happen as well as it should. Let's try and improve. So it's a whole circle there. If something is slightly reckless, where, okay, oh, I was too busy. Well, okay. I think then you get to the next level, which is coach and learn, which is, okay, I understand why you did that. That's not quite what was supposed to have happened. This is what should have happened. And this is what we expect to happen. So you get coach. And there are some people, and it is very, very small numbers, where behavior is truly reckless. And in that situation, we are not here to defend all docs or all nurses. We are here to make things as good as we possibly can for the people using our services. So if that happens, then we do need a capability to correct. And so the important thing is, you have analyzed the issue. You're able to define whether was it a genuine mistake, was it a slightly reckless, or was it slightly risky. So the fair and just culture on the human side of things, to make sure that the people working in your system, so to help them be good, which means you need easy readable guidelines that aren't 60 pages long. You need regular educational support. You need a system to support people when something goes wrong.
Mm-hmm.
All of those things in place, whether something was small or something was big, and in place and process. When you get to a system situation like mid-staffs or Ockendon and stuff, you're dealing with a whole culture
Mm-hmm.
that is more than about one person. Mid-staffs was fascinating. I read the patient stories on a train down to London. It was a very, very sobering train journey. It was truly awful. And what the situation there was, you had a whole culture of reinforcing poor behavior, where not, and it wasn't one bad apple, it was a whole culture where nobody can tell us what to do. We don't want to be absorbed into another health system, which was, I think, one of the issues that they were pondering at the time, the mid-staffs. We don't believe, or the data that we're being told. So, one of the things with mid-staffs was that the hospital standardized mortality ratio, which is it's not a great metric, but it gives you a rough idea if some system is behaving out of the normal corridor of capability. And rather than thinking, we're out of that normal corridor, what can we do about it? Their approach was, we're out of the normal corridor. We don't like that measurement. We think that measurement is rubbish. So they actually
I
published
wonder,
it.
like, that tendency to reject facts.
Yep.
People might be surprised that happens in medicine, but in your experience, are people usually quite good about seeing those numbers and saying, right, okay, well, I better do something about it, or can anybody get that defensive?
Oh, Zach, if you've emotionally invested your whole career into a certain path or a certain treatment, and then unfortunately somebody shows you some data that suggests that that's not the best thing for the patient, you will not let go of that lightly. And then,
Yeah.
not necessarily, your head might say one thing, but your heart will say, oh, well, yeah, but that trial showed, and that was in a different country. And then, you people can find some very interesting ways to justify it. I off the top of my head, the using arthroscopy for knee arthritis, very popular thing to do, doesn't seem to do anything useful apart from keep people needing knee rehab for a few months. A couple of years ago, I went to a cardiology conference around the use of stents in stable angina. Doesn't seem to have anything useful to add. That is serious news to a lot of cardiologists. And I'm sure, and that is something that, oh yes, but my patients might need it. So people are very invested in certain things. So sorry, come back to the culture side of things. You have to, it's a culture, it's a whole system wide. If you get a failure as large as Ockendon or mid-staffs, it's because there are multiple people in the system who are wedded to a less safe system, and people who feel uncomfortable about it feel they can't speak up, or they do not have the channels to improve or to move the story to a safer place, which is concerning. And the Ockendon one is really interesting because it brings back into this idea about shared medical decision making. That cesarean is a very emotive area for both patients and staff. There is this this feel that childbirth should be natural meaning spontaneous vaginal delivery, but the data suggests, because of our wonderful health services, that there is a small but important population of women for whom it is safer to have an elective Caesar than a crash Caesar or a spontaneous vaginal delivery. And if you have a culture that says we don't want Caesars, and having too many Caesars is a bad measurement, then you're going to put that subgroup of people at risk. And also, which brings on to the right measurement. Is the number of cesareans you're doing, as in too high, being a bad thing? Is that the right measurement? So you have to make sure you're measuring the right thing to make sense and to make it as safe as possible. It may be the right thing. It may be that too many Caesars would create large amounts of potential surgical post-op complications, and that therefore there's a happy medium. But you need to be able to dive into that data and make sure everyone is in a safe place for that.
This idea of culture, I think, is one we should spend a little bit of time on. I really wonder whether it's it's possible when the culture goes bad for anybody to do anything about it.
Mm.
Should you just get out when you can? Or actually, is there something that you can do in terms of quality improvement to slowly change the culture over time?
Very good question. If you have a good culture, you will have a culture that encourages you to be part of that culture. As in, you see something you don't like, say something. Don't wait for me to tell you, don't wait for me. And you will be heard, whether you're, regardless of whatever hierarchical structure there is, and you'll have a capability of it. And there will be no repercussions, negative repercussions for you on doing so. I think the staffing at mid staffs was really interesting, because what you saw there was that there was a, a group of a large group of people who stayed, but there were also an significant number of people who came into the situation and left quickly. So, which would suggest that they weren't finding avenues where they could safely raise concerns.
And suggests also that that was an alarm signal that someone should have paid attention to.
Indeed, indeed, and it is one of those interesting measurements where what is happening with your recruitment and retention. Um, are you losing everybody that people who come to work here for the first year? Are they all going somewhere else at the end of the first year? That's an interesting sort of warning thing. Generally, cultures that are open and responsive will have a fairly healthy workforce in that respect, who are quite happy for their relatives to be, and that's to be looked after in that. This is what we do. There's a thing called I Matters that we fill in, that takes opinions from staff regarding how they feel their working environment is. Some people find it a bit annoying to fill it in, but it's actually quite informative about the culture of the place, and it's anonymized, so it's quite a useful sort of way of checking a culture in a place. Um, if if people don't feel safe or heard, then that is a culture that has to come, I'm afraid, from, I'm not a big top-down person. I think it's much better to have narrow hierarchies. But saying that, in teams, everybody has a role, and part of the role of the board, of the chief execs and the boards, is to say, we value safety, we value you. If you have an opinion, we need to hear it. And if you think things are concerning, there needs to be a framework that allows you to say that. So if you're in a culture that closes you down, then that's not safe. And that has to come from an ethos from pretty much from the top, at the top. The best hospitals I've worked in have had highly visible chief execs who you knew on a first name basis. They're out there.
And this is my idea about how the culture work, like, because I sort of think that when culture goes bad, it must be a failure at the top. Um, and I kind of think about how, as a junior doctor, you actually get very little opportunity to impact a wider culture. You're very much at the behest of people who have more responsibility or more power. But the reason quality improvement's interesting to me is that actually maybe it gives you a way to slowly change things over time. Have you seen through your efforts culture changing positively as a result
I
of
think
what
so.
you're
Well,
able to
let's take
do?
that, the point that you're a trainee doc, and therefore less able to influence. I get that. The beauty of doctor training is that you move frequently, a bit exhausting, but it means that you see the good and the bad of many different places. And what I hope you'll be able to see is, that's a culture I like. That culture I'm not so impressed by. Um, that mode of safety process seems to be better than that mode. So you'll be learning throughout this period what is good. And then, yes, you are going to be, you're right, it is you have greater power to change things at a more senior level, but you guys are the seniors of the future and the not too distant future. So this your the point the what you can use valuably at the moment in your training is training, is thinking, I know what good looks like. That's what we need you to do. um, but the other thing is that you should be comfortable, and I think anywhere that you're not comfortable, that's a problem. To be able to say, I have, I have concerns here, or I'm worried here, or I am out of my depth here. I don't want to be made to do that because I do not have the training or the confidence to be able to do that, and I want to be able to say I need support to be able to do that. And this is one of the things why I think the culture is different from what it was 20 years ago, which was see one, do one, teach one.
Yeah.
Genuinely. And I think I am so pleased that it's not brilliant and it's not everywhere, and it's still not necessarily as good as we want it to, but there is more support to be able to say that's something I need help with. So, and I want to see more of that, and to create cultures where trainees can say, I'm part of this conversation, I want. But importantly, my role is to make sure that trainees, if they ever are involved in a safety incident, they are absolutely supported, so that we create a big learning experience from anything that happens. But when you do get to that training, to that slightly more senior point, absolutely, it is part of your role. What have I seen from a change from a culture point of view? Well, since we created this system of quality management, one of the things that I really like is that all my colleagues are bought in. So one of the important things about creating a culture is that you don't have 20 different disparate individuals all basically fighting like, I don't know, frogs in a sack, frogs in a box. If you work together, even with lots of different characters, you create forward momentum for good. And certainly, I work in a culture where everybody is bought in to the fact that we want to know what our service looks like. We want that data, and we are happy to support members of the team in our department to try and change things for the better. What have we seen that's better? So, one of the things that I'm comfortable about in my department, in spite of the fact that we have a prevalence of probably of 50 to 60% people with cognitive frailty on our wards, we have very, very, very small amounts of sedative meds in relation to the level of people with delirium and behavioral psychological symptoms. And we do that because of a caring and kind workforce who don't rush for the pharmaceuticals to try and keep people down. We're a big
Yeah.
fan of tea and de-escalation before we get to the sedation.
Yeah, I think if my granny was confused, I'd much rather she got tea than injection of sedatives.
It's a great treatment. I'm a big fan. And so we know that because we measure it, and because it's so important to us, we will continue to measure it to make sure that we don't trip up with that. One of the things that I'm particularly interested in, as we've mentioned, is the sharing of a medical decision. 7 or 8 years ago, people didn't often discuss do not resuscitate orders. They did sometimes, but not always. And docs felt it was their role to put them in or not roll them in. And if you got that communication, well, it was a bit optional. We have a standard where we want to talk to everybody, in the people who come in through the wards. We know from measuring our anticipatory planning, and particularly around do not resuscitate orders, that we have consistent and reliable high levels, very high levels, where people that communication has happened and agreed before any paperwork is put in, which I think is really, really important. We'd like to invite everybody to have a discuss about future medical wishes whilst they're with us, and that's an ongoing challenge, not just about resuscitation. It's about where do you want these next few years to go? How do you want us to help with that? And that's one of the things that we're working on. But yes, I think we have seen through the work that we've done better communications around future care. We've seen consistent low levels with hospital-acquired infection, particularly around the use of the PVCs, which are a common source of hospital staff bacteremia. We have low rates of use, and we get them out fairly quickly if they're not needed, that sort of thing.
It sort of brings up a little question for me in what you've said about whether the main thing is to have the right systems or whether the main thing is to have the right people in order to promote a good work culture.
Jack, it's the perfect balance. You can't. When I first started this, I used to think, oh, we just need, it's those crazy humans just ruining the system. And the more I have worked in those systems, I think, gosh, those amazing humans fixing these crappy systems. So, and because we work in hospitals that were basically built in the 19th century and have had bits bolted on and things, you don't have perfect ground up beautiful systems that from the, they're very Heath Robinson, so it's a very difficult thing to sort of unpick. But you basically have to do two things. You have to have as safe as systems as you can, and that's a constant systems engineering process. And part of my role in QI, quality improvement, was hacking away and just asking, why are we doing like that? That makes no sense. And there are definite bits to the system that make no sense. And then you deconstruct those and you rebuild them. And that's part of the systems engineering and quality improvement. But also it's about, well, how are the humans functioning in this system? Do they have the right support? Do they have the right education? Do they have somewhere to rest? Do they have somewhere to change when they get on their bike? And are we doing everything that's okay? And there's work to be done with those too. So what you really want is transparent and easy and safe systems and well supported and educated workforce. And both of those are a constant work in progress. That you will never finish. You will be constantly checking, fixing, checking, fixing, checking, fixing. That's why quality improvement isn't something you just tick off. I've done my audit. It's a constant process of polish and fix, and polish and fix.
I like the way that you very eloquently evaded that dilemma that I was trying to pose. No, it was a great answer.
I think the systems aren't perfect. So the question is, you can either say, well, I'm disengaging because the systems aren't perfect, and I am going to be cross every time the system fails, and I'm going to let that human know of my displeasure if something goes less than perfectly. Right. Well, that's one way. I think you'll have a fairly miserable career if you do. And I would prefer to take a more optimistic, there's a lot that goes right, but we can be better. And with a kind approach, which is very important. People, the vast majority of people that I work with are doing their best every day they come to work, and they need kindness and enthusiasm, not denigration and pull your socks up when they're already tired. So you need support and kindness. You need to make the systems better. If you want to see me cross, you'll just see me
No, I never want to see you cross.
when you see my if my computer goes down in my clinic, now that everything is on computer, I need that to work or I can't function. So these are the things we've got to make. Our fabulous IT people need to keep the computers going, and I know we all get a bit cross about our computers, but goodness, Lothian's IT team kept that big nasty virus away, and there was only about 2 of them, and they just beavered over a few, with no sleep to make sure that our computers didn't get taken down by that virus. So everybody's got a role in trying to do their best, and I think we just need to acknowledge that.
Was that a conscious choice you made in terms of like not disengaging? Because at the moment, there's a lot of talk in the media about junior doctor morale being the lowest ever, and possible talks about them taking industrial action. And I just contrast that with, your relentless positivity that actually, it doesn't have to be like that we can do. Where does that come from for you?
I'll tell you, right, okay, I'll tell you where it came from. When I was a trainee doc, I was exceptionally distressed, extremely distressed when things went wrong, and would ruminate and not sleep. And it was to a not a healthy point. And I had to find some good out of things, and with that powerlessness that what you describe, and being able to try and learn and contribute to learn how to fix, to make things better so they happen less than it would be, and to champion people who are also trying to do that, and to team up with people who thought the same way. There are people around who think that. Then that just made things more manageable for me if things went wrong. To know that something, because things do go wrong, unfortunately, because we work there's so many people through our systems, and when it is not a flawless system. And to it was an active decision to get involved because it just felt better to me than
Yeah.
disengaging. I would be actually, it's one of the things I particularly look for in my trainee doctors, because I feel that is not a good way. It's not a safe thing to do. It is not safe for your well-being anyway, but it's not safe because if you are not taking part, if you feel that you are somehow, it's not your responsibility to think about that PVC, to think about DVT prophylaxis, to make sure you're the best surgeon that you can be, that that the chemo dose is right. These things absolutely matter, and they're not somebody else's problem. So I want people who are engaged to if they're going to stay in this profession, because it requires a level of engagement. Um, but that comes back to the well-being, Zach. You're absolutely right. You know, if you're going to create a good rota, that takes time. And if you're going to, the trainee doctors coming into your department should get that rota sooner than the Saturday that before they arrive. And there should be some degree of flex and support if there's important things that need to happen in that period. So it's about, you have to invest properly, you in and make them feel validated and valued. And if they're not feeling, and one of the things that I think is challenging at the moment for trainee docs is non-continuity and the lack of a team. Because if you're coming on a shift being super intense, no breaks, just straight through, disappearing off, and then not seeing the same faces twice, not knowing whether the things that you did, how they impacted on the patient, so you don't learn then that's a lousy experience, which will make you feel, disengaged and afloat, adrift. Whereas if we, so it, we, the people who design the rotas and the working practices need to make sure that there is some element of team, that there is some element of well-being structure, whether it be somewhere to be downtime, and there is some way of continuity of education. And I think too many rotas are badly designed. Too many rotas and working practices are badly designed for trainee docs. I wouldn't say
Yeah.
ours is perfect, but we put an awful lot of time into it.
I would say yours is pretty good compared to
Right.
some of the rotas that I've worked on.
But it
Uh,
matters, because that
yeah,
matters. It matters to
definitely.
your well-being,
Uh,
and I think a lot of the dissatisfaction comes from really poor working practices, as much as remuneration, which is true.
mhm,
When you're doing when you when you've got a highly exhausting and stressful job that is having a significant emotional impact, well, that does need people. That does need to be rewarded because it's hard.
mhm. And linking that back to medical error, and how because it seems that wider national policies, you know, could have a direct effect on that, because if national policies affect how junior doctors are feeling, or the working practices are difficult, do you think that has an indirect effect on some of the issues that we've been talking about?
Oh, entirely, Zach. I mean, entirely. The national. I was a trainee at the London when they took the beds from the messes out and put them on the pavement, because we were working over 100 hours a week, and that we weren't. We were not very safe. I can assure you, it wasn't a safe thing to do. I mean, as in working those silly hours. I think it's very hard, to create a perfect system right from the top. And I think that remains a continual challenge. I'm extremely wary of the super high multiple changes that never seem to sort of fundamentally change things. But they've got to try. The important that will happen. There are people there whose job it is to try and create the safest, fairest system. Depending on where you are on the political spectrum, you may have strong opinions whether they are right or wrong. That's politics, and that will go on perennially. So how do you deal with that? Small is beautiful. You deal with the environment around you. You be the best you can. You create a team that feels supported and okay. You create standards that work in your department, and you build in that. And if your foundation is robust, you can sometimes spread that information, love, training beyond where it is, beyond your bit. But yes, that has to happen locally. And I don't. Anybody who says there's an easy answer to NHS is not seeing it properly, because there isn't. We could spend the whole of GDP on NHS. That's the challenge. There's amazing step forwards in many aspects of care, but goodness, they're expensive. We have a population that is quite highly taxed and feels too highly taxed. Some people feel that they don't need to necessarily take part in that conversation about their own health, and potentially do lifestyle things that might mean that they're going to come into contact with us, which they wouldn't do if they did some lifestyle modification. So it comes back to that, what we talked about at the start, where it's a big conversation about how we use the resource that we have in the fairest way possible, which is we could spend the entire day talking about, Zach.
I want to ask one sort of last question, and that's about, do you think the trends in terms of medical error, do you think hospitals are much safer places now? And I wonder, just about the politics sort of issue looking forward, and some of the things that people are saying about the NHS, about the workforce crisis, about lack of chronic investment, more so in England than in Scotland. Um, but what could they, is there anything that they could do that would make things easier? Are you kind of looking forward going, things might not be as good? Or actually are you a bit more optimistic and thinking, well, the trends, by
Uh,
and large are going to continue?
I, I, I am going to have some more of that ruthless optimism, Zach. The hospitals these days are safer, no question, because, and one of the reasons why the consultants are more engaged, not everywhere, but enormously more than when I was a trainee, and not perfect, but we have quality improvement in safety systems that allow us to see how safe we are, and we can compare in a relative comparison. So I think we have the building blocks of a safe culture, with improvement being embedded through every stage of training, being taken seriously by the vast majority of hospitals. Yeah, the bad eggs absolutely stick out. And I think they are the exceptions that almost dispute the hypothesis. Is it going to get easier? I'm concerned because of two reasons. The nature of the way that we work now, we have to have more docs and nurses, and and docs are expensive to train. The government have capped again the number of docs that's a challenge, because you need the workforce and we need the nurses as well. So we've got to find a problem to the recruit. We've got to recruit more, and we've got to have more, without a doubt. And the other challenge is the resource. Some of these truly amazing treatments are truly amazingly expensive, and we've got to work out how that fits in, and we have got to grasp the nettle of how we support and care for our old frail population, so that they don't have to collapse into hospitals and stay in hospitals being looked after because there's nowhere else for them to go safely, which is we my colleague, the great Brian Chapman, did an extraordinary meeting, a geriatrician, in 2000 and sometime in the noughties, and said, "Look what's coming down the line. We've got to do something."
Definitely ahead of his time.
He was, and no politician has really grasped the nettle, and society hasn't grasped the nettle on that one. Mm-hmm. And I think that's linked in. So we've got some big challenges, but in terms of safety, capability of training, if you actually do get to be a doctor as opposed to not being allowed to be one, it's a safer and a better place than it was. And if you continue to engage and be part of that process, we'll just keep getting better, frankly, within the limit of the resources that we have.
That seems like a really good point to start wrapping up our conversation. I always sort of ask people if there's a particular book which they'd like to recommend that sort of touches on some of the issues that we've been talking about, if people want to go and find out more.
I like this. This is an interesting one. The Fifth Discipline. It's about the art and practice of a learning organisation. Lots of different examples of different ways to work where you're not just set in your ways. Nicholas Taleb, Fragile, Anti-Fragile, I think is a good read in terms of the how you see systems. Have I lent this one? Oh,
well, we're getting 3 for the price of 1.
There you go. Intelligent kindness. I'm reforming the culture of healthcare. Now, I have been accused that might be a bit too lefty for everyone, but I love the title. We're not making biscuits here. We need to be kind to our workforce and the people that come through and use our services.
Okay. Well, Dr. Sarah Keir, it's been an absolute pleasure having you on the podcast.
Well, it's been a pleasure talking to you, Zach.
Thanks. If you're listening to this message, it hopefully means that you've enjoyed this episode of the podcast. Thank you for listening. It's for listeners like you that I'm making this content, and it would be amazing to have your support. The ways that you can support this podcast are leaving positive reviews on social media and subscribing if you're listening to this on YouTube. The more listeners like you who subscribe, the more I'll be able to improve the podcast and make better content for you to listen to. So if you like where this podcast is heading, please consider becoming a subscriber. I'll see you in the next episode.